Our next presenter is Associate Professor Bridget Barber. Bridget is a bit of an all-rounder who, by her predominant interest as a malaria researcher, but also as an infectious diseases physician, commonly frequents the intensive care unit that I'm fortunate enough to work in, but also has a very strong interest in immunomodulatory therapies in COVID, and particularly IL-6 inhibitors. And so we look forward to hearing her summary of the literature for this. Bridget, thank you.
Thank you, Jason. I should say that there's been a fairly dramatic thunderstorm going on around me, so it's quiet at the moment, but if there's any loud bangs or the lights go out, then that's what's going on. So thank you for the opportunity to speak this evening. I don't have any conflicts to declare. At the start of the pandemic, I had been planning a tocilizumab RCT and received some funding for that, but due to the lack of COVID-19 patients in Brisbane, that didn't go ahead. So mine was one of the studies that Stephen put up on his slide at the start with a 0 next to it for patient enrolments. But I should say that from my point of view, that was a fairly small price to pay for having so few COVID-19 patients in Brisbane. And I'm also a co-chair of the treatment panel of the COVID Clinical Evidence Task Force. So this is the list of agents that have been evaluated in randomized controlled trials for COVID-19 and that we've looked at in the task force. So it's a very long list, as you can see. There's a few crosses and even fewer ticks as we accumulate more data as to whether we should or shouldn't be using these agents. But I'm pleased tonight to be talking about one of the agents, tocilizumab, that it looks like there is now some data to support its beneficial effect in COVID-19. So this is a similar slide to Andre's slide that he showed, and as Andre said, it's a simplification, but it does provide the rationale for evaluating IL-6 inhibitors for COVID-19. So there are a proportion of patients who develop this hyperinflammatory response in the second week of their illness with increased acute phase reactants and increased inflammatory cytokines, particularly IL-6, and severe pulmonary alveolar damage with endothelial injury, increased pulmonary vascular permeability, and thrombosis with microangiopathy and angiogenesis. So there's a number of steps that can be targeted to try and prevent this inflammatory response and to try and prevent the downstream pathogenic effects of this inflammatory response. So just to point out a few of these on this slide, there's the JAK inhibitors, ruxolitinib and baricitinib, and baricitinib in fact has now been included in the recovery trial, and these inhibit the JAK-STAT intracellular signaling. There's the IL-1 beta receptors, canakinumab and anakinra, and then the IL-6 receptor inhibitors include cetuximab, tocilizumab and sarilumab. I'm only really going to be talking about tocilizumab this evening because that's obviously what we've got by far the greatest amount of data for. I'll just briefly mention sarilumab at the end. So tocilizumab is a recombinant humanized monoclonal antibody that blocks soluble and membrane-bound IL-6 receptor. It's licensed in Australia and elsewhere for rheumatoid arthritis and for CAR T-cell induced cytokine release syndrome. Early on in the pandemic, there were a number of observational studies and case series that were suggestive of potentially positive outcomes in COVID-19 patients. And in fact, there were a number of clinical guidelines in some countries that actually recommended tocilizumab for treatment of COVID-19 just based on this observational data. There's now been a total of 9 randomized controlled trials looking at tocilizumab, although only 8 reported a mortality outcome. There were inconsistent results from the initial RCTs without any demonstration of a mortality benefit. But then on the 9th of January, the REMAP-CAP preprint was published demonstrating a mortality benefit in critically ill patients. But then only just very shortly after the publication of this REMAP-CAP preprint, there was a study published in the BMJ by Vega et al., the Tocibras study, which had actually been halted early by the DSMP due to an excess number of deaths at day 15 in the tocilizumab arm. So up until a few weeks ago, the data was really out for tocilizumab, but then on the 9th of February, so fortunately just in time for this webinar, the recovery trial preprint came out demonstrating a mortality benefit with tocilizumab. So I'm going to spend quite a bit of time talking about the recovery trial, as has been alluded to earlier on this evening, just because of the sheer numbers of patients in the recovery trial. In any meta-analysis, it's really the recovery data that has the overwhelming influence on the overall results. So everyone's familiar with the design of the recovery trial. For the tocilizumab randomization, this occurred as a second randomization. So patients were enrolled into the main study and randomized into well, up to 3 arms as part of the first randomization. And then if they met the criteria for progressive COVID-19, then they could undergo a second randomization to tocilizumab or to standard of care. And the criteria for, or the definition of progressive COVID-19 was oxygen saturations less than 92% on room air or receiving oxygen, and a CRP greater or equal than 75, and within 21 days of the first randomization. So patients could undergo this second randomization immediately after the first randomization or any time up until day 21. And in fact, the median time between the first randomization and the second randomization was 0 days, with an interquartile range of 0 to 1. So the large majority of patients were randomized to the tocilizumab component shortly after the main randomization. The exclusion criteria was that tocilizumab wasn't available at the study site or that there was a contraindication to tocilizumab. Dosing was weight-based, so patients received either 400, 600 or 800 milligrams according to their weight, and it was given as a single infusion, and then a second dose could be given 12 to 24 hours later. Even the opinion of the treating clinician, there had been no improvement, and this ended up occurring in 30% of patients in the tocilizumab arm. There was only a single follow-up data collection point, which occurred at day 28 or at day of discharge or death, whichever was earlier. And the data collected at that time point is listed there. And safety data, as also has already been mentioned this evening, was quite limited for pragmatic reasons to enable the inclusion of as many sites as possible. So safety reporting is limited to serious adverse events believed with a reasonable probability to be due to one of the study treatments. So the less severe adverse events were not reported. So this is the study flow chart. So during this period of time, there were over 20,000 patients enrolled into the recovery study, and this box here lists the study agents that patients received as a result of the first randomization. 19% of patients then went on to the second randomization to be randomized to either tocilizumab or usual care, with just over 2,000 patients in each arm. Importantly, of those allocated to tocilizumab, only 83% were recorded as having received tocilizumab, and the reasons for this were not recorded. This is the baseline characteristics, so I won't go through all of these, but just to point out a few of the important points. Patients were a median of 9 to 10 days following symptom onset, and a median 2 days following hospitalisation. Around 13 to 14% were receiving invasive mechanical ventilation, and of the remainder, it was fairly evenly distributed between non-invasive ventilation and no ventilatory support. This is the median CRP, which is comparable to the earlier tocilizumab RCTs, even though a high CRP was an inclusion criteria for the recovery study. And importantly, the large majority of patients in the recovery study were receiving corticosteroids, so 82% in both arms. And this is an important difference between the recovery study and some of the earlier tocilizumab RCTs. So this is the main results. So for the 28-day mortality, it occurred in 29% of patients in the tocilizumab arm compared to 33% of patients in the usual care arm, with a risk ratio of 0.86, 95% confidence interval 0.77 to 0.96. There were also differences between the arms with the secondary outcomes. So for patients in the tocilizumab arm, there was a shorter time to being discharged alive. A higher proportion of patients in the tocilizumab arm were discharged alive from hospital within 28 days. And amongst patients who were not receiving invasive mechanical ventilation at randomization, a smaller proportion went on to require invasive mechanical ventilation or to die. And there was also a smaller proportion of patients in the tocilizumab arm who required renal replacement therapy. And this is the Kaplan-Meier curve there of the primary outcome, the 28-day mortality. So the results were fairly similar across the subgroups, including by ventilatory support. And the main difference here was with the use of corticosteroids. So that you can see here that the beneficial effect of tocilizumab are seen to be much more marked in those receiving corticosteroids compared to those not receiving corticosteroids. And as I mentioned, this is possibly important in terms of interpreting some of the earlier tocilizumab RCTs. So there's obviously a number of limitations with the recovery study. Some of these have been mentioned already tonight. For this particular tocilizumab preprint, information on primary outcome is available for only 92% of patients. Sorry, I don't know if you all heard that thunder. This is expected to increase to more than 99% by early March, so hopefully we'll have that data shortly. As I mentioned earlier, following randomization, 17% of patients in the tocilizumab group were not reported as having received tocilizumab. So whether they didn't receive tocilizumab or whether the documentation of it having been administered couldn't be located, I think is not entirely clear. The study is open label. I think this is, I don't feel that this is particularly likely to bias primary outcomes of mortality. As has been mentioned, there's minimal safety data collected. And I've just also put down the bottom here a question about the generalizability, just because of the fact that the mortality in the recovery study is higher than has been reported in many other centres. So that's just something else to keep in mind. So this is a summary of the other RCTs that have evaluated tocilizumab. So I've listed them in chronological order. So the first one was the COVAXIA study that came out in September last year. It's a preprint. I think it's still a preprint as far as I'm aware. It was a study that included severe to and critical patients. Importantly, along with the recovery study, it's actually the only study to separately report outcomes for severe patients and for critical patients. There was no difference in the mortality at 28 days, but there was a shorter time to discharge and a shorter duration of ICU stay in patients in the tocilizumab arm. And you can see there the proportion of patients on steroids was higher in the control arm than in the tocilizumab arm. These next three studies were smaller studies, and if you look at the mortality rates with two of these studies, it's likely that, I think it's likely that these studies were underpowered. None of them demonstrated a difference in mortality, and the steroid use was lower in these studies as well. This one was a study done in France, this one in Italy, and the back-based study was done in Boston. The IMPACTA study came out in December last year in the New England. This was a study that included moderate to severe patients. I should say that none of these studies here included critical patients, except for this COVAXIA, REMAP-CAP, topograph and recovery. So the IMPACTA had an emphasis on including minority, racial and ethnic groups. Again, no difference in mortality, but in this study, they did actually meet the primary endpoint, which was a reduction in the composite endpoint of death or mechanical ventilation, which was reduced in the tocilizumab arm compared to the control arm. And the steroid use in this study was higher also than some of the other studies. The REMAP-CAP, I think everyone's familiar with, demonstrated the mortality benefit in critically ill patients, and you can see there a high use of steroids in all the patients. The TOCABRAS study I've mentioned already, this was the one that was stopped early by the DSMB due to an excess of deaths in the tocilizumab arm at day 15. This difference in mortality at day 28 is actually not statistically significant, and it was just a small study. So it is possible that difference at day 15 may have just been by chance. And the recovery study, obviously, I don't need to go through again. So this is the meta-analysis of all those 8 trials. This is the meta-analysis as published in the recovery preprint. So you can see here these first few studies that didn't demonstrate a mortality benefit. Then this REMAP-CAP study, which seemed to be a bit of an outlier in terms of demonstrating benefit with tocilizumab. This was the TOCABRAS study that was stopped early. This is the recovery study here, and then this is the overall. So overall risk ratio of 0.87 for mortality with a 95% confidence interval of 0.79 to 0.96. This is a meta-analysis of some of the other outcomes from those 8 studies. This is data produced by Heath White from the Clinical Evidence Task Force. So I'd just like to really thank Heath for this data. So in addition to the reduction in mortality, there's a likely reduction in requirement for invasive mechanical ventilation. There's probably a reduction in proportion of patients being admitted to ICU, probably a reduction in patients, or sorry, yeah, an increase in the proportion of patients being discharged from hospital, and probably little effect on or serious adverse events and adverse events. This will hopefully be up on the clinical evidence task force by the end of the week. So just to briefly mention sarilumab, there's only, as far as I'm aware, only 2 randomized controlled trials. Sarilumab, like tocilizumab, is a monoclonal antibody that inhibits binding to both the soluble and membrane-bound IL-6 receptor, and it was included in the REMAP-CAP study, but in much fewer numbers than tocilizumab. So there were 48 patients in the REMAP-CAP study who received sarilumab compared to 402 control, and it was around 350 who received tocilizumab. There wasn't a statistically significant reduction in mortality with sarilumab compared to control, but the numbers were small, so it's hard to really make any definitive conclusions from that. There's one other RCT that's just been published as a preprint. This was a slightly larger study with 406 patients randomized to either 200 milligrams or 400 milligrams of sarilumab or to placebo, and there was no difference in mortality, and there was no difference in their primary endpoint, which was an improvement in a clinical scale. So in conclusion, tocilizumab probably decreases all-cause mortality in hospitalised patients receiving supplementary oxygen for COVID-19, particularly those with systemic inflammation. It likely decreases the need for mechanical ventilation. It should be given in conjunction with corticosteroids, as it was in the recovery study. Dosing should be as per the recovery trial, and it's unclear whether other IL-6 inhibitors can also be used. So that's my last slide. Thank you, Jason.
Thanks, Bridget. Fantastic presentation. If I could ask any of you that have any questions about IL-6 inhibitors to put it into the Q&A box, and then hopefully Bridget will get a chance to answer those soon. Thanks, Bridget.